you are exhausted from all the treatments that have not worked to ease your chronic pain, like pain medications, injections, physical therapy, chiropractor, TENS, nerve ablations, nerve procedures, spinal cord stimulators, surgeries, etc. And it might be time to consider a new approach and what that new approach looks like. Okay. And remember, guys, whatever I share with you, it's all research-based. It's all evidence-based. This is not my opinion, or this is not just a theory, okay? So it's very well studied in last 10 to 20 years, and that's what I'm sharing, the data. And our medical industries has not implemented that stuff. It is coming at some point, but not as much as we would like to see. Hi, I'm Dipti Patel, physical therapist with 20 plus years of experience, therapeutic pain specialist and a yoga teacher. Don't forget to subscribe and click the bell so you get notified when my new video is released. I have so much information that I can't wait to share with you, so you embark on your pain-free journey and live fearless, active life. Let's talk about a story. Let's look at the common scenario, okay? So you guys, some of you might be familiar with this. Let's take a look at Jane. She is 32-year-old female. She has 2 children, 5-year-old and 3-year-old. And her husband works, but travels a lot. He's gone pretty much weekdays. He comes back on the weekends. Jane also takes care of her disabled mother, okay? So she's pretty much single mother during the weekdays and takes care of a lot of responsibilities. Now, one Monday afternoon, she was taking the trash out and her back went into a spasm. Tuesday morning, she wakes up in excruciating pain. She had a hard time getting up out of the bed. She had to take care of her, get her kids ready, drop them to the school or a preschool. And she came back and lay down. After 2-3 days, her pain was not easing up. Finally, she decided to see a doctor. She got an appointment Friday afternoon. She goes to the doctor. She said, well, let's do an x-ray. And I'm going to give you 800 milligrams of ibuprofen. Take this. She gives her 60 pills. And we're going to do an x-ray. And then we'll report the x-ray results to you. So she doesn't hear from the doctor back till Monday about the x-ray results. And the doctor doesn't call her. The nurse calls her. And she just read the report as it was written down by the radiologist. And it says you have a problem at around your L4, L5, or L5S1 disc, and you have a degenerative disc disease. Now, who doesn't have a problem at L4, L5, or L5S1? I have been a physical therapist for 21 years. And I have not seen any single x-rays or any single person who does not have a problem at L4, L5, or L5S1. If you're above 20, you're going to have something cooking in that area between L4 and S1. It's just a common area to get some abnormality in. Okay. So, well, the way the nurse reads the report and says you have a degenerative disc disease, and after that, she puts the phone down. Now, Jane starts worrying because her mother is disabled because of the back pain. So now she's realizing, oh my goodness, am I going to be like my mother? Am I not going to be able to do things? I'm not going to be able to take care of my kids. And all this fear and anxiety builds in, okay? So sometimes people have their friends, or they have seen a neighbor or another uncle or aunts who have gone through a severe back pain and has totally made them disabled. And all that stuff, if you had culture, environment, or experiences in the past, that just puts up a lot of fear and anxiety about what this is going to take. Now, she follows doctor's advice. She took ibuprofen. She lay low for 2 weeks, and her pain does not go away. So after 3-4 weeks, she calls the doctor and says, hey, my pain is not getting any better. Doctor said, no problem. We're going to send you to a physical therapy. Well, she has to wait for another 2 weeks to get for physical therapy. Then she gets in physical therapy, and one time she just had an evaluation done. She got a couple exercises to do at home. And then she goes back again. And after 3, 4, 5 sessions, her pain seems getting worse. And then somehow the physical therapist gave her exercise that just really made her back angry and painful, that she just decided not to go back to physical therapy. So she puts up with the pain for some time, and then finally, after it's 3 months passed by and her husband pushes her to go and see the doctor again, she comes back to the doctor. Doctor said, okay, let's do an MRI. So the MRI comes in and she has to wait for another 3 weeks, 2 weeks to get an MRI done. It takes another 3-4 days for the doctors to read the MRI and send her the results and let her know. Now, again, the MRI is going to show more wear and tear, right? That puts more anxiety and fear in Jane's mind. Now, doctor says, okay, I'm going to send you to a pain management physician and let's see what they can do. So another 3-4 weeks she has to wait to get in to see them. They said, well, let's do the injections, or we're going to try injections in that area, and that will help you to give you some relief because you have tried this. So pretty much, so pain management physicians gives her injection. Well, that gave her great relief for 2 months, but eventually the pain came back. So she goes and see him back again. By this time, it's already 6 months past, okay? She gets another injections, and this time the only relieved the pain for 2 weeks. And she goes back, she calls them back again, and they say, well, we're going to try another injections if you want, or we can try this medication or this one or that one. Well, the life goes on, right? Things goes on and on and on. So what is wrong with all these things? How our industry is set up? So first and foremost is the approach we follow is find it, fix it, right? Find where the pain is. So if you say you have a low back pain, they only want to x-ray the low back and find out what the problem is and fix whatever you find that's wrong in the x-ray. Same thing applies to a shoulder or a knee pain or the ankle pain, x-ray, find what's wrong and then fix it. They don't realize it that there are 40 to 60% people out there, you're going to find the same abnormalities, but they don't have a pain. So why are we chasing this x-rays and MRIs to fix the problem? That's a number one problem we have. Number two is the insurance guidelines. The insurance says x-ray has to be done first, then the person should go to physical therapy, then the MRI needs to be done, then this needs to be done. Even though doctor knows very well that I should have taken steps differently. I should have done things, maybe order an MRI first, maybe ask a patient, sit down with them and ask, hey Jane, this is your x-ray results and how does that make you feel? What do this is what it says, but share them some data, share them that are you really scared, worried, see what that perception is rather than just reporting it. I know they're busy, they don't have much time to spend with the patient, but there's a lot of things can be done in 15 minutes. The other thing wrong is, so first is find it, fix it, and then the insurance guides the doctors what to do. So I only can speak about the United States because that's where I work and that's where the system I have seen. I can't talk about any other countries, how the system is laid out. But that's a big problem that we are making decisions what insurance companies lay down for us, right? The number three problem second problem is the the bottom up approach. So we start from the bottom. So we start from treating the lower back. So we treat the joints or the disc or the facet, the vertebrae or the muscles around it by doing physical therapy or the injections in that area or the manipulations or all that stuff, right? When that doesn't go away, we give injections in that area. We give the pain medications to calm down. So all that stuff is concentrated in that bottom area where the pain started. Then if it doesn't go away, we look at the nerves, right? So we give TENS unit or we do nerve ablations or nerve blocks and try to block the nerve from taking the pain further up. So we are further going up towards that. Pain still don't go away, then we look at the spinal cord stimulators or surgeries and stuff like that. And that still doesn't go away. Then we say, well, you might want to see a psychologist. You have so much anxiety and you're depressed with this. So if you see a psychologist, this is going to help you, right? So everything starts from the bottom and then we go up. right? By the time it's too late, you have made this pain lasted way longer than it's supposed to. And remember, there's 1 out of 4 women or the men globally goes through this chronic pain cycle. That's a 25% of population. We should have done way better care within that first few months by targeting, asking a right question. I know that is not every single person is fearful or having anxiety about this pain, but if we would have asked the right questions from the beginning, that are you fearful? Are you scared? There are questionnaires out there that primary care physicians can promote and find out that how this fear can cause the pain catastrophization from the very beginning. And then the third approach is we are laser focused on that area. So if everybody's looking at L4, L5, they only want to fix that area. They want to work on the muscles around it. Maybe they look at the hip, and maybe some physical therapists look at the thoracic spine, but that's all the focus is. In medical industries is really don't want to look at the whole holistic approach, that mind and body is connected. In order for a person to make a whole person, the person's stress level, their diet, their sleep, their emotions, their relationships, what their responsibilities outside, all that stuff makes a huge role, and that does impact your pain and your overall health. So those are the things that are really big time missing, that we are not even paying attention to it. The other thing in physical therapy is they just focus on that area and now looking at the whole body. And we're going to talk about that. In order to do that, how can you treat a person as a whole functional unit rather than just focusing on that area? So we did talk about this 22 treatment ideas and modalities that are evidence-based. And out of these 22 things, there are like a breathing, yoga, tai chi, aquatic therapy, coping skills, sleep hygiene, journaling. There's a lot of things you can do it by yourself. And there are a few things here that you need the professionals to help you with. So these 22 things are not all you can do it by yourself. You do need a professional help for some of them. And that's what I want to talk about. That's what I have implemented those things in my practice. And these are the 22 things that can help with the chronic pain. And again, you don't have to do all 22, but this might help you to calm down the nervous system sensitivity, and can take a step further in your recovery. Now, these are the 4 fundamental things that research supports and that helps with the chronic pain. Number 1 is a cognitive-based therapy, and we'll talk about there are 3 different kinds there. The second thing is a brain-based drills. The third is the neurodynamics. And the fourth is the functional mobility exercises. Now let's talk about a difference. And I put them in the 4 phases, and each phase follow the other phase after a person has successfully finished the first phase. So the first is the cognitive-based therapy. Second is the brain-based drills. The third is the neurodynamics. And then the fourth is the functional mobility exercise. And we'll talk all about them in a detail. So the first is the cognitive-based therapy. Now there are 3 well-studied cognitive-based therapies out there. First one is the pain neuroscience education. That's called PNE. And that's the one I used, pain neuroscience education, with my practice. But there is also cognitive-based therapy called CBT, and acceptance and commitment therapy, that's ACT. And a lot of pain psychologists uses those for their patients, treating their patients with the pain, or even for the other stuff too. But those are the 3 highly research-based, very effective treatment guidelines for persons treating with the pain. Now, what this does is, when you understand the pain at the deeper level, it helps to take your fears down. That's the number 1 thing helps with the cognitive-based therapy. The more you understand the pain, The less the fear you have, the less muscle guarding you have, though you move with the ease, and your muscles, your actin and myosin filament starts moving easily in the muscles, and your joint starts lubricating. There is not much resistance in the body, and that starts your nerves gliding and sliding, everything starts moving easier, and that's the first step. But by itself, if you just do the cognitive-based therapy or the PNE or the acceptance commitment therapy, it's not that effective. It is effective, but it will not 100% get rid of your pain. Okay. Now, next is the brain-based drills. And in the brain-based drills, it's as we talked about, not in the last one, but there are 3 kinds of pain. And also in our first one, what is pain? That there is a lot of functional and structural changes happens in the brain itself. So in the brain, spinal cord, and nerves. But the brain-based drills helps to restore the structural and the functional areas of the brain. And there's a lot of drills I practice with my patients. And again, we want to test, I usually test my patients with the several different drills and find out the speed and the accuracy and compare them with the normative values, and whatever areas there are deficits on, we focus on those drills just to restore those maps. So it will be like left side and right side discriminations. It will be 2 points versus 1 point. Like, do you feel they have to keep their eyes closed? And in that painful area, we use the discriminators, or you can use the what do you call the paper clip opened up. And is it a 2 point or is it a 1 point? We do like draw the numbers or the alphabets, and they have to tell which alphabets or which numbers they are. I use different fabrics, and they have to tell me what kind of fabric is it. Is it silk, or is it a fleece, or is it a cotton, or is it a mesh, and stuff like that. And you will be surprised. Some people have a very difficult time, and some people don't. But we have to find out first in order to see that how much their area is affected. So that's a second step. The third step is a neurodynamics. So the nerves are, as we talked about in our 3 types of pain, that in the neuropathic pain, the nerves can get not able to move, and they're not gliding and sliding. So we follow this neurodynamics where we glide and slide the nerves to restore their mobility and make them more robust and vibrant and less irritable and painful, so we can move on with our next step. And the next step I usually follow is called SFMA, which is segmental functional mobility assessment based exercise. So what I do is I check the patients from head to toe. And why? Because we moved as a whole function unit. When you bend over to pick up something, there are 20 joints in the body's moving. When you twist around and look behind you, all the way from your second vertebrae to your big toe, everything is turning and twisting to look behind you. So if somebody comes and they have a hard time turning their head, and you only treat their neck, but you don't look how their thoracic spine is moving, how their hips are moving, how their tibia and fibula is moving, and how their ankle is rotating, and if they have enough pronation in the foot, you're going to keep torquing this neck over and over and over again if you not make the whole body system work as a one unit. So that's a big problem. Even some of the physical therapists will treat the shoulder and the upper back, but I don't see them treating the whole body. Sometimes when I remember, and I used to do this myself, that if person comes with the big list of problems, that they have a knee pain, ankle pain, back pain, and I used to say that just pick one. I can treat everything in this one session. So let's pick one and we can start from there. And it gets frustrating. But now, since I've been doing this approach for some time, I don't have to ask them that pick one. I just write down wherever they're sore, and then we start working on in the entire body mobility and bringing more function. So rather than focusing on the one area, we focus on more function. So these are the functional mobility exercise, and it has a further I divide them. That is the joint moving right. So we're going to fix the joint first. Is the muscles working right? Is the muscles is flexible enough? And now then we're going to work on muscle flexibility after joint starts moving. Then we're going to work on the mind and muscle connection first. And then the last part is a muscle strengthening. That's where we do TheraBand exercise and core stabilization and so forth. And in many physical therapy practice, they start focusing on the muscle strengthening from the get-go. And I think you're going to make people sore if you just start with that approach. So functional mobility exercises work much better when you focus on the and painful part, we leave it alone. We don't even touch it. That's painful because it's moving too much. So we treat all the other dysfunctional area before we come and start focusing on the painful area. Now, this is how it follows. So I do PNE first, pain neuroscience education, and then we test again, see if they have made any improvement on their couple scales. And if they have, then we move on to the brain-based drill, or we call it graded motor imagery. That's where we sharpen the maps in the brain. And then after they have come to all the normative data on all the tests, then we move on to the neurodynamics, where we make the nerves robust and start moving, gliding them and sliding them easily. And then the last part is the segmental functional mobility assessment. Segmental functional mobility assessment can take maybe 7 or 8 sessions, depending on how dysfunctional you are. The more people are restricted and tight in their joints, takes the longer. But quite a few times I come across that people have the motor-mind connection missing, and those usually respond pretty fast. So that's the best way to, whenever the person has gone through pain for longer than 6 months, immediately, don't wait for 1 year, 2 year, 3 year, 5 years. The sooner you start with this approach, the faster you're going to get them out of this pain cycle. Because remember, the longer the pain stays, the stronger the pain is. It takes longer time to get them out of the pain. So I wish the medical industries takes that step and helps and starts incorporating some of this in their practices. All right, any questions, guys? If you have any questions or any concerns, please comment below and I will be happy to answer them. And thank you again.